All good.
Okay, so last week or last fortnight was brain diseases, which was obviously a massive field that we were nowhere near going to be able to cover. And obviously brain diseases are made up of so many small diseases. So I do really want to emphasize how important it is to read the chapters, particularly through all of neurology, like all of the kind of myopathies, myositis, and neuropathies, neuritises and things like that are such small diseases that there's no way we're going to cover all of them in the scope of these rounds. So neuro is one that's just a whole heap of little things that you need to sort of remember, and there's no really big way of looking at it apart from, I think, going through differentials, like having a patient case-based sort of, and then going through the different differentials you should have in mind. Today's topic is vestibular disease and cranial neuropathies, which I thought went nicely together given vestibular disease is sort of a cranial neuropathy. Is there anything specific that people want to cover? I think we've promised that Josh will explain paradoxical vestibular syndrome to us.
Oh no, I forgot about that.
I nearly sent you a reminder. And it was like,
I wish you did. That's all right, I'll try.
No, it's so fine. But what I want to talk about is the normal function of the vestibular system and the components of the vestibular system, and then it will be really obvious what will happen if you've got a cerebellar lesion, which would cause paradoxic vestibular syndrome. So is everybody happy to cover that? Normal vestibular function so that we can understand abnormal a little bit better? Yep. And then the other thing, I've got a list of the 5 most common cranial neuropathies that we see. And I just want to sort of go through those 5 predominantly. And then the others, I think, they're so rare that you can read about them in the textbook if you need to make a differential list clinically in your clinical lives. Okay, I'm going to try and share my screen, but I just took some screenshots of an article. There's an excellent article in vet clinics in North America on vestibular syndrome, and there's another one in the veterinary journal which is so detailed, which goes into all the different kind of causes of central vestibular system as well as peripheral. But this is a picture from the vet clinics in North America one. So you can see, okay, what are the components of the vestibular system? When we see a clinical case, what are we trying to differentiate? It's written on the screen in front of you.
Yeah.
Yeah.
Peripheral and central vestibular disease.
Exactly. And why is it so important to try and differentiate as best we can between these two?
It's quite a different set of differentials most of the time as well. Yeah,
absolutely. So what is the purpose of the peripheral vestibular system?
I feel like I'm the only one talking, sorry. I was just going to say it's to do with balance. So there's a good picture at the top there of I can't read it, I think it's like the semi-something ducts.
I've blurred it deliberately to make this hard for you.
Oh, okay.
Sorry, I haven't.
Essentially, it can tell which way is kind of up and detect movement.
Yeah. So they're called the semicircular canals. And those canals, one goes kind of caudal to cranial, one goes lateral to lateral, and the other one goes horizontally. So we've got sort of the 3 different planes, 3 dimensions of movement. And these little dots down the bottom of those semicircular canals are the actual nerve part, the sensory part of this. So these canals contain fluid. So when you move your head a certain way, the fluid in those canals moves. So say I tilt my head to the left. The fluid in this one is going to move up like that. The hairs in this little sensory part are going to lean to the left. And that's going to send a nerve signal up through the vestibular system, beg your pardon, the vestibular nerve to obviously the central vestibular system. So then what happens? How is my body going to respond to the fact that I'm leaning to the left?
It's going to signal the left side of the body to, or stop inhibition to the left side of the body, so that the left side of the body can put more pressure to correct that. I think it's probably a silly way to say it.
A fancy way to say that would be increasing extensor tone. So that's one of the effects. What else happens? So let's turn out, close your eyes, put your fingers over your eyeballs and turn your head. What happened?
Works.
It works.
Huh.
I love this experiment.
So creepy.
It's not a visual thing. So the vestibular input synapses both on the vestibular spinal tract, which goes down to your extensor muscles. So it increases. So if I'm leaning to the left, my body wants to increase tone in my extensors on that side to stop me from falling over. But it also wants me to see where I'm falling. So you're going to get a fast phase flick of your eyes towards the side of your falling. So that's physiologic nystagmus, and it's not visual because it happens when you've got your eyes closed, which we've just demonstrated. There's a couple of other things that synapse on. So you can see in the picture down the bottom. So we've got the vestibular nuclei going down to the vestibular spinal tract, so the spinal cord to increase extensor tone. We've got it going up to the muscles of the eyes to provide the doll's eye reflex, so oculomotor trochlear abducens. And then we've also got it going to the cerebellum. What's the cerebellum's role when there's vestibular stimulation? What's the cerebellum's role even without vestibular stimulation? If you've got a cerebellar abnormality, what does your gait look like?
Hypermetric.
Good.
So does it smooth you out, sort of?
It smooths you out, exactly. So the forebrain and brainstem signals are really rough. They're get out of trouble in a hurry signals, like quick, increase your extensor tone, and quick, move your legs forward, and it's really uncoordinated signals. The cerebellum's role is to smooth all those signals, and it actually does that by inhibiting those signals a little bit. So we get this huge reaction at the vestibular nucleus, and the cerebellum, it synapses onto the cerebellum, and the cerebellum says, whoa, you don't need to increase your extensor tone that much, you're going to fall over the other way. So the cerebellum's job in vestibular responses is actually the opposite of the vestibular response. So it decreases that signal. So they're the three main things that happen when we get our vestibular system senses that we're moving. So increased extensor tone, and I should say decreased extensor tone on the other side, which allows you to correct. So increased flexor tone, decreased extensor tone on the contralateral side. Eye movement to see where you're falling to, and the cerebellar response to smooth and coordinate that, all three of those responses. Okay, so say we've got a patient that's come in with peripheral vestibular disease. knowing what we know about the kind of anatomy of the vestibular system and clinically, obviously, what are the clinical signs we're going to see in a patient with peripheral vestibular disease, and how are you going to know it's peripheral rather than central?
Normal mentation.
Excellent.
There'd be no long track signs as there would be with central.
I love that it says that in all of the references, but it's so hard to check proprioceptive responses in a dog that's crocodile rolling. It's wild. And so I actually find judging symmetry in a vestibular dog almost impossible. Okay, good. Normal mentation, no long track signs. What about the nystagmus?
With central vestibular disease, you'll often get a vertical nystagmus. With peripheral, you'll get more likely horizontal or rotatory, but with central, you can also get those as well. So I think only if you've got vertical, you can lean more towards central.
Okay, excellent. And what, rotatory, you said can be both. Good. And what about the speed of the nystagmus?
Yeah, fast is more likely peripheral. So if it's less than 66 beats per minute, I think you are more likely to be central.
Excellent. Thank you very much. Did everybody know that? That was such a light bulb for me in my fellowship study.
I've never heard that before.
Yeah. Does it make sense to you? I mean, if you sort of, in your clinical experience, seeing dogs with central versus peripheral vestibular disease, is that your experience?
I think so. I have very rarely seen central, so I can't actually recall seeing it slow.
Yeah, we're pretty spoiled, obviously, having access to advanced imaging that we actually get to confirm them often. And obviously our patients, we're very spoiled, but it's really nice to see that kind of correlation. So if you've got a really slow nystagmus, it's almost certainly going to be central in origin. Good. So we've got absence of long track signs, mentation, normal mentation, and horizontal nystagmus versus vertical nystagmus. So it's going to be at a fast rate in this patient that has vestibular disease. What about their degree of being able to right themselves in peripheral versus central? Not telling.
Not too sure, but
Not too sure.
I figured it could be similar both ways. But if I'm going to guess, potentially if it's peripheral, they may be more challenged to right themselves.
Yeah, absolutely. So the crocodile rolling dogs are much more likely to be peripheral. That's a grey, it's sort of soft finding. And we certainly see central dogs with really profound vestibular abnormalities. But the thing with central is that the vast majority of lesions we see causing vestibular deficits, they take up a lot of space, and the vestibular nuclei, right and left, are literally millimetres apart. So the chances of seeing, you might see one that is causing predominantly left signs, a lesion that's causing predominantly left signs, but the chances of it being so profoundly affecting left over right or vice versa are pretty slim when there's only that 2 millimetre gap between nuclei. So this doesn't really demonstrate it that well because we can only see cranial nerve where cranial nerve 8 comes out, but the nuclei are right in the middle here, sitting right next door to each other. Okay, so is there anything else we should cover with differentiating central versus peripheral? I think we've named the main things. What about other cranial nerves being affected? So say we, oh, sorry, go ahead.
I was just saying we've had one, had a couple with middle ear disease causing peripheral vestibular signs, but also have had cranial nerve 7, the facial nerve, affected as well, just because of the proximity to the bulla,
Good.
the petrosal bone.
Good, excellent. So with peripheral vestibular disease, the differentials for peripheral vestibular disease are otitis media. The facial nerve runs right through the middle of the bulla, so can be impacted as well. So just because you've got 2 cranial nerves affected doesn't mean you've got a brainstem lesion. It might mean that you've got a middle ear lesion. So what about if you had some facial sensory abnormalities as well as vestibular signs and facial palsy? What nerve does facial sensation?
Trigeminal.
Excellent. And is that allowed to be affected if you've got peripheral vestibular disease, or does that confirm that you have central vestibular disease?
I feel like they run really close together as well. I can't remember exactly where that one runs, but I feel like it runs quite close with the facial nerve.
Yeah. So if you have a look here, 5's coming out there, facial's coming out there, vestibular's coming out there. So it might not necessarily be in the brainstem lesion, but it could be a lesion of the bone here where they're coming out, or it could be a lesion of inflammation where they exit the skull. So it doesn't necessarily mean it's central, but I'd be looking closer to central and looking at this. If you look at on this MR, if you look at the kind of middle ear apparatus here, this is where all this stuff is up here. And that's where your nucleus is. We're not talking about big distances. It's right there. So differentiating central from peripheral, we're talking about sort of 2 millimeters more. So if I had 5 affected, I'd be looking more central and wanting to optimize imaging that optimize the bone as opposed to the nerves, maybe, although the nerves are very valuable too. Okay. All right, let's talk about paradoxical syndrome. So, are we ready for that yet? Do you want to have a crack, Josh, having just talked about the role of the cerebellum?
Sure. So
Well done.
a very basic version of, well, my very basic understanding is that because it's an inhibitory response at that level, inhibiting the same side, I think it is, if that inhibitory effect is taken away because of central vestibular disease in that area, you will get an increased excitatory response on the ipsilateral side, causing them to kind of push more off that side and then tilt to the opposite side. So say if it's the left, they'll push off the left and tilt right. So it'll look like a right-sided peripheral vestibular lesion, but it's truly a central left vestibular lesion, is my understanding.
Very good, Josh. Did everybody understand that? Does anybody else want to repeat that back again?
There's probably a much clever way to explain the anatomy. I just can't remember it.
No, that was absolutely perfect. So it feels like a double negative for me. So it always takes a really long time for me to comprehend this. But we've lost inhibition on the ipsilateral side. So we've got increased extensor tone on the ipsilateral side, same side. So our head tilt is going to be pushed to the contralateral side. So I think Josh probably explained it better than I did. So the head tilt normally, if you've got a vestibular lesion and you've got decreased extensor tone because your vestibular nuclei isn't working, your head tilt is going to be towards the side of the lesion. But if you've got a loss of inhibition of your vestibular nuclei, your head tilt is going to be the opposite way. So what other clinical signs can help point you? So what direction will our nystagmus be in a paradoxical vestibular syndrome? It's the same reflex. It's the extensor tone reflex.
So is it opposite then? I thought it would have been the same. As in
slow phase or
fast phase away from the lesion.
Fast phase towards, actually.
Okay.
So if you think about when you tip over, your vestibular nuclei says extensor tone on that side, increase extensor tone on the side that you're tipping towards, and move your eyes quickly towards where you're falling. So fast phase to the left. So if you've got loss of inhibition, you're going to have increased fast phase towards the side that you've lost the inhibition on. Make sense?
Yeah.
Okay, what about proprioception? Ipsy or contra?
I'm not sure. I'd be guessing.
So ipsilateral, same side. And what about if you had concurrent facial and trigeminal nerve impacted?
Do you mean what effects you would have?
No, would it be ipsilateral or contralateral?
Oh, right. Ipsilateral.
Ipsy, good, exactly. So cranial nerves and proprioceptive deficits are going to be same side. Head tilt and nystagmus are going to be opposite side. So your cranial nerves and your CPs are you give away that it's paradoxic, because otherwise you'll just describe it as the wrong-sided vestibular lesion. Excellent. Thanks, Josh. Josh has had a brutal week and I just put him on the spot. So if everybody can give him a pat on the back when they see him, that'd be great.
Thanks, Anna.
No worries. Okay. So what are the differentials for peripheral vestibular disease? Let's give him a break, guys.
Otitis media.
Excellent. So that's by far the most common cause, and is massively underdiagnosed. What stat did I see? Even on CT, there's false negatives in 17% of patients with otitis media. It can be really hard to diagnose. And where does otitis media come from? How do we get it?
Maybe it's normally ascending because I guess you don't often see ear lesions in these dogs. I'm just guessing it comes another way.
Yeah, which way?
Up the eustachian tube.
Good, exactly. So what breeds of dogs might be more predisposed, and cats for that matter, might be more predisposed to otitis media? Brachycephalic, exactly, because they're so crowded. They've got so much redundant mucosa in the back of their throats that their eustachian tubes in the middle ear can't drain through that eustachian tube. So we see almost like a glue ear develop. Cavaliers were the kind of classic breed that we saw this in originally. But now we're seeing it more and more in bulldogs and Frenchies. Jeff, I'm not sure what's going on with your settings. Sorry, I just got your comment there. I might stop sharing my screen and then it will just go away. Is that all right?
The North Side veterinary specialists. Now I can see your face.
I turned the video off somehow. Sorry. That's annoying. I wasn't looking at myself either, as you can see. Anyway. Oh, it's not Emily at all. It's Paul. The video's working now. Hi, Paul.
Hi, Paul. Didn't see you there either.
Yes, so brachycephalic dogs and cats with chronic rhinitis, where they've got thickened mucosa in the caudal nasopharynx, where the eustachian tube's trying to empty out, are really predisposed to ascending infection in the middle ear. What about, see, now I'm going, now that Paul's here, I'm going back through everything I said about nystagmus and eyes and going, was that right? No.
Don't worry. Everything in the ophtho textbook's wrong. It's really bad.
Oh, so Paul's doing a ophthalmology internship / residency. Are you resident yet? Not yet?
Yeah, I'm a resident. Yeah.
Okay. Excellent. So I will defer to him now that I know he's here for any eye thing.
Please don't.
Okay. So otitis media, the other ways we get it are extension from external ear canal. So we've all had those crusty otitis externa that the tympanic membrane is nowhere to be seen and there's pseudomonas everywhere. And then the other way is actually hematogenous, which I don't know how you kind of document that that's how it happened, but it's reported to be one of the causes of otitis media. Do you guys know what the most common bacteria are in there, or can you predict based on the fact that most of them are ascending?
That'd probably be staph.
Yeah. Staph, pseudomonas, anaerobes sometimes as well. So what antibiotics are you going to choose if you're suspicious of otitis media?
Clindamycin.
Excellent.
Especially if you've got bone penetration.
Absolutely. So clindamycin's a great choice because it covers the spectrum of bacteria we see most commonly, but it also penetrates bony spaces, and particularly, I mean, the bulla is an air-filled space. It's like trying to kill an infection that's sitting, you know, outside the animal, essentially using systemic antimicrobials. So it's a really hard space to get into. So clindamycin penetrates anaerobic spaces quite well. Good spectrum for the bacteria we're looking for, and we'll get into the bone, which is we've often got a bulla osteomyelitis as well as infection inside the ear.
In the Riverina, grass seeds were not uncommon because the grass seeds would penetrate the eardrum and just keep going.
Yeah, right. I can't remember if I've talked about this in rounds, but I had a dog and it had epistaxis, and the owners were convinced it had leeches in its nose because reportedly it actually sneezed out a leech the day the epistaxis started, and then it had epistaxis for the next 3 months. And it came in and it came in to me, and I looked up its history. I was like, I have no idea what to do if there's a leech in this dog's nose. And I looked it up, and there's reports of people having leeches in their ears, in their like abdominal cavity. They just go everywhere. They sound like
please stop.
The best part of this story is that one of the recommended ways of killing leeches when they were in body cavities or inside the nose was actually cocaine in medical journals.
Awesome.
And listed right next to cocaine was saline. Who tried
pick one.
They used to use cocaine to test for Horner's syndrome, to test if it was
really?
Yeah. It was commonly used, and it's still the recommended drop to try and dilate the pupil of some birds because, right. I don't know how you get it.
CH2 sells
I'm
it.
not telling.
You know CH2, the supplier. They it's on their. Well, it was. I don't know if it is anymore, but it used to be.
Wow.
I know. I was surprised.
It's actually still listed as like a medical use in the States as a level 1 substance that vets can't prescribe, because vets can only prescribe level 2 and below, and cocaine eye drops are in level 1.
Yeah, there you go.
I never had any use for them, so it didn't come up as a problem.
So funny. Okay, sorry, we digress as usual. Okay, so I want to move on from vestibular disease to the cranial neuropathies. Is there anybody got any questions about vestibular disease?
I just had a question about, sorry, Anna.
Yeah.
Do you, if it's really hard to diagnose otitis media, if you can't find anything else, are you assuming that it, you're going to treat them with clindamycin if it's a brachycephalic? And also, is there any sort of vascular origin of peripheral lesions, or are the vascular causes only central?
That's a really good question, and we probably should talk about idiopathic, like geriatric vestibular syndrome, as probably, whilst otitis media is technically more common, we actually diagnose idiopathic geriatric vestibular syndrome more commonly. So vascular causes of peripheral, probably, but very hard to diagnose. So do you know what, I mean, nobody knows what causes idiopathic geriatric vestibular syndrome. That's why it's called idiopathic. But they think it's a demyelination problem with the peripheral vestibular nerve. But they don't know what causes the demyelination, and they suspect it might be vascular. And they suspect it's associated with hyperlipidemia, because we see hypothyroid dogs, Cushingoid dogs overrepresented. So that's sort of short answer. We don't really know, but probably vascular, given how sudden onset it is, demyelination doesn't make sense. So I think something triggers, like a vascular event to the nerve potentially triggers the sudden onset of vestibular syndrome, and then the demyelination is the injury that follows that we detect histologically, potentially. So that's sort of one of the working theories.
I read some years ago, or not too many years ago, that it was usually associated with a hypothalamic lesion in a particular area of the hypothalamus, which I can't remember.
So that's definitely, I completely agree with that. So there was a shift. We had all these dogs that were lumped in idiopathic geriatric vestibular syndrome, and now about half of them are being diagnosed with stroke, the central vascular lesion, and the other half still remain unclassified, so idiopathic. And those dogs have no central lesions seen on MRI or CT. But theoretically, small transient ischemic attacks can not show up any changes on MRI or CT. So theoretically, we could be seeing like a very small stroke just to the vestibular nuclei on one side, but we're talking like 1 millimeter. And why would that then be accompanied by demyelination peripherally, which sort of doesn't make sense. So Jeff's just written, would somebody put together a summary of the signs of seen in vestibular disease? Josh, you've been volunteered.
Yeah, I think I might have one, I think, in my notes for members.
If you wouldn't mind sharing it, Josh, that would be awesome.
Yeah, sure. No worries.
I've got my fellowship notes here, and I don't have a nice table, but there's so many out there of central versus peripheral vestibular disease. Now, Brian, I feel like I missed a component of your question.
I was just about antibiotic. I guess because I don't think I've ever considered otitis media when I couldn't see an otitis externa. And I know I haven't imaged any peripheral vestibular dogs, so without imaging, and say if it's not, I guess you signalment might help there, whether it's an older dog potentially with an endocrinopathy, or potentially a younger brachycephalic, that's going to push you potentially to an antibiotic trial. Would that be right? Yeah.
So certainly breed. External ear examination just doesn't tell us anything, and often what we're seeing these dogs for is actually a facial palsy and a mild head tilt. it's not that kind of really acute onset rolling vestibular symptoms. It's much more subtle vestibular symptoms, like a unilateral strabismus on neuro exam that hadn't been noticed elsewhere, sort of thing. So when we sort of say vestibular symptoms, the duration of onset, signalment, degree of signs are really going to make me kind of change my differential list.
Okay. Yeah.
The classic ones are the like dogs with dry eye because they're not blinking properly because they've got a facial palsy, and then you go, oh, I've actually got a strabismus as well. Let's image the middle ear.
Yeah.
And as far as outcome with antibiotics, it's pretty poor. Like, I don't think we clear them very well. Then the next step is a bulla osteotomy, which is massive and comes with risk to the facial nerve. You know, you're not necessarily fixing the problem that the patient presented with by doing that. So given that they're sort of asymptomatic for their otitis media, often we'll use sort of pulse therapies. If they don't have a tympanic membrane and they're tolerating topicals, we'll use those. Often I'm slow to recommend a bulla osteotomy just because of the morbidity associated.
Thanks.
No worries. Okay, so moving on to the 5 most common cranial neuropathies, vestibular syndrome is one of them, so I'm going to sort of tick that one off the list. But say I've got a 6-year-old male neutered staffy who comes in with wasting of the temporal muscles and otherwise unilaterally on the right side, and no other clinical signs, eating well, drinking well, owners say very happy dog otherwise. What's your approach to this dog going to be?
Happy to have a go. I'd want to run a CK, apart from the general kind of normal minimum database. On top of that, I'd run a CK. Probably the top things I'd be thinking of is if we have a myopathy or a trigeminal neuropathy. They're the top things in my mind. So you could look at doing advanced imaging. Probably an MRI would be best.
Good
scenario, and potentially a muscle biopsy.
Good. Excellent. What would be the highest thing on your differential list with the signalment and presentation?
What was the signalment again? I missed that.
6-year-old males neutered staffy.
And it's just the one.
Just one, completely unilateral, other side's perfectly normal.
Probably a trigeminal neuropathy, I think, just given that it's the muscles of mastication.
And what's the leading cause of a trigeminal neuropathy?
Is it a trauma? No neuritis of some kind?
Hypothyroid?
No?
I'm going to go idiopathic.
Hey, good one. That's a good choice.
Okay, we're going to have to go to damn it. Specifically the N.
Neoplasia.
Yes, excellent.
Oh, that's so sad.
It is so sad. What's the most common? What's the most common cause of? It's not a real dog, Josh.
It just came out of nowhere.
Okay. What's the leading neoplasia that would affect one nerve?
It's going to be like a Schwann cell tumor or something weird, like
Schwannoma. Yeah.
Peripheral.
Yeah.
Like the nerve sheath. Yeah.
Exactly. Yeah. So nerve sheath tumors, staffies are overrepresented, which is why I gave you a staffy. They really like the trigeminal nerve. Don't know why. but certainly the other differences that you mentioned there, neuritis and things like that are also common problems, but nerve sheath tumor is the most common problem of a focal single cranial neuropathy.
Is it, oh, sorry, can I ask, is it like a neuritis, when you get like a neuritis or idiopathic or whatever in that area, is it chronic enough generally to cause the muscle wastage, or is that a bit of a giveaway? If that makes sense.
Sorry, what was, so
So
you
like,
said again, sorry.
if you have some other cause like a neuritis, is it generally like a chronic enough process to cause the muscle wastage?
Yeah, it happens. So muscle atrophy from disuse takes weeks and weeks, like it's quite a long process. Muscle atrophy from like neurogenic starts within a week. It's really fast.
Okay.
Yeah. So if you've got decreased nerve signals, just decreasing muscle activity, it's going to fade away really fast. So certainly the most common cause of unilateral trigeminal neuropathy. What would we see if we had a bilateral trigeminal neuropathy?
Dropped jaw.
Good, excellent. Anything else?
Decreased facial sensation.
Facial, yeah.
Facial.
Excellent.
What you said first, Josh?
Sorry.
What you said first, I missed that.
Oh, I dropped jaw.
Oh, okay.
Yeah.
Drop jaw, you mean symptom, not a cause.
Symptom, yeah. So a bilateral trigeminal neuritis or neuropathy will cause a drop jaw, so that jaw just sits open, and they can often present for trouble eating or trouble prehending food, and they can't close their mouth. It's just flaccid, so you can manually close their mouth for them, but they can't. Is your mower back? Who is that? Oh.
Yeah.
Right.
The drop jaw, is that one often idiopathic?
Yeah, it is.
The bilateral, because I think I had a nurse whose dog had that last year, and there was sort of no determined reason, and it resolved on its own.
Yeah, so it's usually a neuritis. So we usually call it trigeminal neuritis as opposed to idiopathic, but without a biopsy, we obviously can't say that for sure. And we get neuritis, focal cranial nerve neuropathies of trigeminal, facial, vestibular, that we detect. Any others? Do you get optic neuritis? Yeah. So there's sort of idiopathic inflammatory conditions that just target single nerves quite often, but we don't really know why. Interestingly, with that drop jaw, the trigeminal neuritis, only about 33% of them will have sensory deficits detectable. So it's often just the maxillary branch. And about 10% of them will have Horner's syndrome as well, which is interesting. Why would that be, Paul? Not telling?
Neuro is my kryptonite here. Horner's.
Aren't the eyes part of the neuro system, Paul?
They are, yeah. Okay, so around the eye.
Me?
And Horner's syndrome, I need to get better with it. I really do. No, I'm just going to butcher this. I'm sorry. Yeah. No, I can't. I mean, the sensory portion of that is interesting to me because the way I see the specialists try and localize the trigeminal nerve a lot of the time is we stick a pen up their nose and see if they go like, and if they don't, then we're like, it's trigeminal. If they come, usually when we see these cases, they come for a keratitis that's not resolving. And then they come in and that's when we're like, oh no, this is, and then we quickly ship them off to someone who knows what they're doing. Out the door as fast as they're in. Yeah.
So why did I get a keratitis with trigeminal?
Oh. I think they just, they don't have as much reflex blinking. So they're, but it is a bit weird. Usually it's a facial that causes the keratitis, but yeah.
What nerve is responsible for corneal sensation?
Corneal sensation. Oh, the trigeminal, yeah.
Yeah.
See, I should know this stuff, but
So if they can't detect that as a dry, they're not going to do
then they won't blink. Yeah,
exactly. So
yeah,
you said
neurotrophic dry eye.
yes. What other symptom might you see when you examine the dog's face?
We usually see the muscle wastage. That's the sort of classic.
Yeah.
And then we see the dry nostril is the sort of giveaway.
What I'm after. Yeah. Can you explain what that looks like to everybody?
Oh, I've got some good photos. Let me see if but that's the giveaway. If you get a unilateral dry eye that's not responding to treatment and it's unilateral and the nose is dry as well, it's like the game's up. It's always neurogenic.
It's always a medicine case.
It's always, someone else. And we just, oh, have I got a good photo? No, I can't find one, but I do have some somewhere I can send around. But they're usually really bad. Like they're usually crusty as.
Google xeromicteria, XERO.
I was trying to remember in my mind the word.
XEROMYCTERIA.
We do dog on there as well.
Is there a dog?
No, I'm just assuming if you search it on its own, probably humans. It's kind of gross. So.
Yeah, humans, crusty noses. Ew.
We do also see really early in the piece. Sometimes the only giveaway is they'll have like zero tear production, and then if you look at the really, I'm not even sure what anatomically the part would be called, but basically the very back of the nose tip where it sort of rolls over. It'll be a little bit dry there on that side compared to the other. And that's also the sort of that with like a Schirmer of 0. And yeah, that's the.
At an alar fold?
The alar fold. Yeah, that would be, just there, just around there. Yeah. That's where it tends to go dry the first. Yeah.
Yeah. All right. That's your homework, everyone. Xeromicteria and neurogenic dry eye. Causes of neurogenic dry eye. We worked one of these up together actually at where do we work? Northside. Cool. Do you remember we did the CT and I made you guys look at the path that the trigeminal nerve takes and you came up with a petrosal bone?
Yeah.
That came in handy. We had one this week, Hannah.
A petrosal bone, yeah.
Yeah, petrosal bone.
Yeah.
Because it's the portion where the two nerves are closest when they exit the brain. Yeah.
Which two nerves?
The trigeminal and the vestibular. Yeah. No, it's the crossover of the. What's number? Oh gosh. No, and the facial. Yeah.
Good. Facial. Definitely facial.
Yeah, definitely the facial. Sorry.
Good. I was trying to give you a hint, but I was too slow getting my photo up. So facial plus trigeminal without vestibular is going to be peripheral. And it's probably going to be where the nerves come out through the petrosal bone to go where they then go.
Do you see that often or? Yeah, because it's one of the big optho, this is going to be an exam question because it's so important. And then I asked Jeff how many he's seen and he's like, not one. So
that's so weird.
Really?
Yeah.
So funny.
But maybe they don't come to us. People know better.
Okay, so the last of the 5 most common peripheral nerve lesions. So nerve sheath tumors was one, otitis media, another one, otitis interna, trigeminal neuritis, number 3, vestibular syndrome, number 4, and then the last one is just idiopathic facial nerve paralysis, which we've kind of talked about in the context of other neuropathies. What are the differentials for, it's idiopathic, nobody really knows. What comorbidities should you test for if you see a patient with idiopathic facial nerve paralysis?
Like a I don't know if this actually might be way off topic, but I was going to say, like, are there neuromuscular junctionopathies or some things like that?
If you have bilateral facial, then I think that's really reasonable for sure. But if it's unilateral, normally it's more a focal disease, but it can be associated with a systemic disease.
Is there an association?
Hypothyroid.
Good, Bron. Sorry, I missed what you said, Sam.
Is there an association with Cushing's?
There's an associated with hypercholesterolemia. So more commonly seen with hypothyroid dogs. And with Cushing's dogs, treating Cushing's doesn't get rid of the symptoms, but with hypothyroid dogs, typically their signs will resolve, the facial nerve paralysis will resolve within 2 months of supplementing T4 thyroxine. So there's kind of causation established with hypothyroidism and facial nerve paralysis. But again, if there's any vestibular signs, ruling out otitis media with a facial nerve paralysis should be a priority. Now, while we've got Paul, celebrity, do you want to talk about Caverna syndrome? Did you say he's never coming back?
Yeah.
About what? About what? Sorry.
Caverna sinus syndrome.
Oh.
So the reason I'm quizzing Paul on this is because one of his ophthalmology supervisors wrote the paper on this.
Yeah. It was Jeff, wasn't it?
It was Jeff.
Yeah, because oh no, I honestly I'm not. I'm not up to scratch with this at all. So don't.
So it's just an interesting syndrome. It's so rare, but we're seeing a little bit of a burst of crypto happening at the moment, and it's something that crypto tends to go in this location, so worth potentially talking about in our last 2 minutes. So I'll just put this picture back up and see if this sort of demonstrates it. So cranial nerve 3, what is it?
Oculomotor.
Good. 4. Wait. 4. What's that one? Good. Excellent. And 6.
Abducens.
Excellent. So what do all 3 of those do in the eyes?
Like eye positioning. I think.
Yes.
Maybe like strabismus if any of those are affected.
Excellent. What about pupil size?
Oculomotor performs constriction, I think.
Yes.
Is that right? Is that right? I can't read that one.
Yes, it is. That's right. Okay, so this area of the brain, so these nerves 6, 4, and 3 come out and they run along the cavernous sinus, which is this kind of sinus at the bottom of the brain, to come out right at the front of the brain. So they run together through here. Now, if we've got a pituitary lesion, if we've got something that's extending from the oral cavity up into the brain, or if we've got crypto extending from the nasal cavity into the brain, it tends to squash this area and results in this really specific syndrome called cavernous sinus syndrome, where they've got mydriasis, they have 0 physiologic nystagmus, and if it's lateralized, you'll still get a PLR. So if you shine a light in the right eye that has no physiologic nystagmus, you'll still get a PLR in the left eye because the optic nerves are still intact. So we get light stimulation in the bad eye, going through the optic nerve up to the bit of the brain that does the rest of the optic stuff, and sorry, I can't remember what it's called, and then back down through the oculomotor nucleus, which isn't affected, through the oculomotor nerve, which isn't affected, and to the contralateral eye. So you get a consensual PLR, but not a direct PLR. So it's just an interesting syndrome, and there's not much else that causes that combination of eye signs apart from a lesion in this location. So it just really helps you to localize. And beg your pardon?
Oh, sorry, I was just going to say, would you have a decreased corneal response as well because the abducens is affected?
Absolutely. Yeah. So you're not going to get globe retraction because you don't have an abducens response. And I would imagine you wouldn't have dry eye because you can still blink and you've still got corneal sensation because 5's intact. Yeah, so it's just those 3 that run through that sinus. All right, I think we're wrapping up. Now, most of you probably already know, but I have resigned from NBS and I'm finishing up at the end of March. But I will be continuing to do these tutorials. So I don't want to sort of pepper people with emails if they're not interested in doing it, but I'll put, if you're interested in still being notified when we're going to be doing them, maybe flick me an email at Northside. I'm still a director and shareholder at Northside, so I'll still have that email address. Flick me an email and I'll make sure I put you on the list and sort of notify you as we're doing them.
Cool.
Right.
Cool.
Thanks, Anna.
Yeah,
No
thank you,
worries.
Anna.
All right.
I'm certainly.
Thanks, Anna.
So what are you going to do?
I'm just going to do some mobile work for a while. I just have a bit more flexibility and time with the kids and stuff. Do a little time out.
Yeah, I heard that your other partner who broke his hip has also left NBS.
No, that's a rumor. Where'd you hear that one?
Rumors going around.
Yeah.
No, he's been on leave for a while, but he's coming back end of March.
Yeah. Okay. And just you're leaving.
Just me. Yeah.
Oh yeah.
And we are actually recruiting for a medicine specialist. So if anybody knows anybody, send them our way. Anybody good?
Yeah. Yeah. Well, I'm semi-retired, so I'm not going back to full time. Okay.
Oh, we'll cross you off our list, Jeff.
Traumatic sitting on the cutting edge.
Yeah, this is why I'm going home to be a mummy. Lower expectations, sort of.
Yeah, I'm just getting sick of vaccinating healthy dogs at the moment.
Yeah, me too. All right, we'll wrap up and we will see you all in a fortnight. Or what are we studying in a fortnight? Do we know? Spinal disease, peripheral neurological disease, the rest of the neurological section. Okay.
Thanks. Bye,
All right.
guys.
Thanks, Anna.
Thank you so much, Anna.